I'm an endocrinologist by education, so I treat patients with obesity, I treat patients with type 2 diabetes, but I've been doing research on fatty liver for a long time. I remember when we started doing research on fatty liver, it was way less, or we knew way less at that time. There was way less interest at that time, and I always tell the anecdote that when I was going to present at national meetings, we ended up next to the restroom where nobody cared about that, and that has changed a lot. And now you go on fatty liver, and you go to the liver meeting, and 80% is fatty liver. You go to the ADA, the American Diabetes Association, and there's a lot of interest. So that's important. We are moving forward in the sense that people are starting to pay more attention to fatty liver. So it's good that we have these types of, so that we can educate ourselves. I hope you learn from me. I learn from you as we go. And as I said, we will keep this informal, so feel free to interrupt me. I do have slides. Usually that's the way we go, but I don't get any bonus to finish my presentation. So if you want to interrupt, just feel free, you raise your hand, okay? So, and as I said, so I'm not a liver doctor. So I do treat patients with fatty liver, but that's where my scope of practice ends. So I don't see patients with hepatitis B or C. I don't see patients with other liver disease. They have diabetes and they need help managing that. So I will be focusing specifically on what we used to call fatty liver, and you will learn that some definitions are changed as we go to make things a little bit more complicated, right? Yeah. Okay, so now we have metabolic dysfunction-associated steatotic liver disease, MASLD. And once you have inflammation, so the first name is just when you have fat in your liver. If that goes into inflammation, cells dying and scarring tissue, we call it metabolic dysfunction-associated steatohepatitis, MASH, okay? So this is kind of question to try to answer for you. So we will talk about names because naming is taming, right? So if we understand what we are talking about, we understand what the doctors are telling us, why this is important, who is at risk of this disease, why some people develop fatty liver. You may be wondering why they have this, and then what can we do about it, okay? So yes, it's very confusing. Even in the field we are confused. Even primary care physicians are confused. And it's no surprise in the last, or since we described this condition, and we call it non-alcoholic fatty liver disease, 43 years, we have 3 names and 3 definitions. So probably the only disease in the world with 3 names, 43 years. So we used to call it, as I said, non-alcoholic fatty liver disease. And the problem was that it was an exclusionary diagnosis. So we rule out other liver diseases. If we couldn't find a cause, we would call it, and you had fat in your liver, we would call it MASLD or non-alcoholic fatty liver disease. So people didn't like the idea of a negative diagnosis where you had to rule out other things. We wanted a positive diagnosis that had a criteria that we could do and diagnose it. I won't talk much about this one, but there was this problem with the use of non-alcoholic. It created some stigma for patients. So in 2020, they changed it to MASLD. And still in Asia, that term is very popular. So you may still see it if you Google it, or if you talk to a doctor, they may use MASLD. Lately, in December 2023, Delphi's consensus, 700 physicians got together. What's the best name we can give it? We don't like the word non-alcoholic. We don't like the word fatty because it could be stigmatizing for patients. We changed it to this very hard word. I had to practice for a month to say it in front of you without a problem with my Argentinian accent. Finally, we have this metabolic dysfunction-associated steatotic liver disease. You have fat in your liver. We exclude other causes. That's still part of the diagnosis. But then you have one cardiometabolic risk factor. Either your blood sugars are not normal, you are overweight or obese, your blood pressure is not normal, or you have high triglycerides, or the good cholesterol, the HDL, is low. So if you have fat in your liver, as long as we know you don't have viral hepatitis or you don't take any medication that could be damaging your liver, then this new condition. So this is just a joke, but it's hard in 15 minutes without using the word fatty, because it's stigmatizing, to explain to the patients what they have without, again, using the word fatty. So, but well, this is the term that probably will stick around, because there was a process that a lot of patients, now all societies endorsed this term. So MASLD is what we have and what we should be talking about. Okay, as I said, we talk about, and I will still use the word fat. It's offended. Fat is a lipid, right? It's a lipid that it's solid at room temperature, so I will still call it like that. I've been using it for many, many years. Steatotic liver doesn't sound as catchy, I would say. But so MASLD is the presence of fat in your liver. And some people may have fat in the liver, but they have what we call isolated steatosis. They only have fat in the liver. It's not a completely benign condition, and I will show you that your cardiovascular risk factors are already increased if you have fat in your liver. But for your liver per se, if you only have fat and you don't have the inflammation and the scarring tissue, it's relatively benign for your liver, okay? But you still have the increased cardiovascular risk, so we should not neglect that condition. And then if you have some inflammation, then we talk about MASH, and that's a progressive liver condition, where because of that inflammation, you can develop scar tissue or fibrosis, eventually lead to cirrhosis, hepatocellular carcinoma. So in one, we have, if you want, two different kind of conditions affecting the same patients. Because they have fat in the liver, they can end up with end-stage liver disease, and that's what we are talking about here. But as I said, I'm an endocrinologist, so I also care that if you have fat in your liver, even if your liver is doing relatively well, you still have increased cardiovascular risk factors. You are prone to develop type 2 diabetes, you have high blood pressure, and dyslipidemia, so your cholesterol is affected. Yes?
Sorry, real quick question here. If your high blood pressure is controlled well with medication, is it still a risk factor?
So compared to someone that never had high blood pressure, yes, but that's statistically speaking, right? So if you have it well controlled, your risk is lower than someone that the blood pressure is higher.
So it's still a risk, right?
Correct. But for diagnosis purposes, if you're on medication, it counts as a cardiometabolic risk factor. Yes.
Thank you.
The good thing is that the liver disease is reversible, even stage 4. Okay? Stage 4 is what we call cirrhosis. Okay? We don't know what's the no turning point, okay? But some patients that have stage 4 compensated cirrhosis, didn't have any complications, can still regress the scarring tissue, okay? That doesn't mean everybody stage 4 can do that. We still don't know what's the point that there's, even if you improve your diet, weight, you start medications, some people are able, some others don't. We call that the no turning point, but we don't know what it is, okay? But so we want to be hopeful, enthusiastic about that, because even if you were told stage 4, that doesn't mean it's irreversible. You have compensated cirrhosis. We see it in trials all the time, patients that stage 3, stage 2, with intervention and medications that we will discuss. Yep.
On the graph, if you have the isolated steatosis and you work on your diet and exercise and you are able to get rid of some of that fat on the liver, can you totally reverse it?
So fat actually is quite easy to decrease. If you only have fat, and we'll talk about treatment, but if you only have fat, 5% weight reduction usually improves all of your metabolic factors and decreases fat. You can have regression of MASLD where you don't have that 5% that we tend to use. It's abnormal. You revert that. Sure. Yeah. It's hard with the fibrosis. I said it is possible, but it's harder. It requires more weight loss, medicines, surgery, and so forth, okay? This is important because this is very prevalent, okay? If we look at different studies, I would say roughly 1 out of 4 people in the world, 25%, have a fatty liver, okay? That's at least fat in the liver, and that's in the overall population. If I look specifically at patients with 60%, and that's the same if you have type 2 diabetes. So obesity in type 2 diabetes, 1/3 of those patients will have a fatty liver, okay? And that's why this is important, because even if the majority of patients will not progress to any small percentage of that prevalence, a lot of patients with cirrhosis. And then usually we say of those with 25 of the population, 25 of those will develop inflammation and a more progressive liver disease, okay? Of those, 10% will end up with what we call advanced fibrosis, stages 3 or 4, okay? Again, percentages may not sound as high, but we start with a very pool of patients, 1/4 of the world population. We have lots of patients walking there with liver disease that are unaware that they have that disease. Okay, this is the fastest growing liver disease. It would probably become the number 1 of liver transplant, and that's because now we have good treatments for hepatitis C. So hepatitis C, the need for liver transplant is coming down pretty nicely, and alcohol is kind of stable. But with the obesity epidemic, we see more and more need for liver transplant with this condition. And obviously a lot of burden for not only patients, the healthcare. So we need to do better at early diagnosis and trying to avoid complications from this disease. This is just to show you that this goes hand in hand with obesity. Okay? That doesn't mean we don't have what we call lean muscle. So you can be lean. For example, if your parents had type 2 diabetes, then you are more prone to be what we call insulin resistant, which is, I will show you the whole problem here. It's this insulin resistance, that your body is not responding to insulin. You're good. Okay. Your body doesn't respond to insulin as well as it should. But obesity is one of the main drivers. So we will leave this lean muscle aside because that represents a small percentage of patients. So as obesity increases, the prevalence of this liver disease increases. So very important that we focus on the epidemic of obesity because it's what is driving this fatty liver disease. And this is going up prevalence-wise through the years. So this is just a graph. It doesn't, numbers are not important, but just to see how much is changing, okay? And that's because the obesity is going up. And now we see kids that are obese, and they have liver disease, and we see patients that are kids that have advanced fibrosis. That's how serious obesity is, not only in the US, but worldwide. And we know that fatty liver disease is associated with several metabolic conditions. Somebody alluded to kidney disease. So yes, kidney disease and fatty liver is associated. It doesn't mean kidney disease is associated with all liver disease, although at very late stages, there is, once it's really affected, the other one can get affected too. But that's a different story. That's called hepatorenal syndrome. It's very severe. Usually patients are admitted. But in patients walking around, the relationship between liver and kidney is because these obese patients have a systemic disease, okay? Through the presentation, I will try to convince you that yes, your liver is important. Yes, we are here discussing your liver, but if you have a fatty liver, you have a systemic disease that is affecting most of your organs. And that's why it's important to tackle the core of this disease, weight, diabetes. And That way, we will not only be improving your liver, but also your cardiometabolic risk factors and your chances of having a heart attack, a stroke, so forth. And you can see several, once your metabolism is altered, it can affect your heart, your kidneys, liver, PCOS, sleep apnea, and I could go on and on. Cholesterol, hypertension, etc. And at the end of the day, we are talking about this not only because it's prevalent and it's progressive, but because it can also kill us, okay? So this is to show you that once you have fat in your liver, I told you it's a relatively benign liver condition. If you only have fat in your liver, you can see that liver-related mortality is not very different than if you don't have a fatty liver. So there's only very little liver-related mortality, but you can see how your heart disease is already markedly increased. And then if you have the inflammation, and especially if you have the fibrosis part, stage 2 or higher, then on top of your cardiovascular disease, you add liver complications, okay? So every person with metabolic disease is different. Some patients may have more kidney disease and end up in dialysis. Other patients may have more liver disease and can develop cirrhosis. What determines what way your metabolic disease goes? There are several factors. There's no point discussing them right now, but we never know. So we need to focus again on the core of the problem instead of just looking, oh, let's just focus on the liver, because then we are not changing your cardiovascular disease. This looks complicated, but the only point I want to make here, so these are the stages of fibrosis, okay? And we know that mortality goes up as your stage of fibrosis goes up, okay? If I was a hepatologist, a liver doctor, I would be telling you how important it is to focus on fibrosis, and that's the most important thing. However, I'm not a liver doctor. So I want you to see that even if this is your overall mortality, so it's higher, the numbers don't mean anything to you, this is patient year, it's a very specific way, but you can see your overall mortality is higher. And you can see that your liver-related mortality is also higher. But if you do this minus this difference is even higher than your liver-related mortality. All that difference is cardiovascular disease, because patients with fatty liver die mostly of cardiovascular disease, way higher than liver disease. Yes, if you have cirrhosis, especially if you are decompensated, well, yes, now the liver is the main problem, but that's a very small percentage of patients. Most patients will die of cardiovascular disease. Again, the reason to focus on diet and drugs that will help you with this metabolic problem. Questions so far? Because we will switch a little bit gears now, and I will talk about how little primary cares in general know about fatty liver disease, so you are the best advocate for yourself and for people that you know that may have liver disease. And there's also misconception among patients, so this is generalized. I do think the field is changing. In the last 2 years, since 2022, we've had 3 guidelines on fatty liver. Can you imagine? So 3 different societies coming up with recommendations on what to do for patients with fatty liver. ACE, endocrinology, ASLD, the Liver Society, and ADA, the Diabetes Society. And this is just in the US. So there's a lot of interest, and we know education is key. But it takes us time to get everywhere, okay? So you will be good advocates of all the education you get here, you will multiply it, okay? So doctors also lack understanding of MASH and diagnostic and therapeutic options. And this is gastroenterologists and hepatologists, okay? They are spearheading fatty liver, okay? So they are the ones writing guidelines. But this is just general GI doctors, not specifically people doing fatty liver. And these are just common errors. It doesn't matter to what the errors were, but obviously not all patients need liver biopsies, but there's a select group that do need. But only 1/4 of gastroenterologists and hepatologists were recommending liver biopsies to their patients. 57 were only relying on liver enzymes, which is a not very sensitive way of diagnosing liver disease. That's why it gets missed many times. The cutoff points we use in clinic are wrong. So, and we will talk briefly about that. There are some drugs that are, and we will talk about drugs at the end. I don't want to get ahead of myself, but there are drugs that we use for other conditions that help with fatty liver. One of those is pioglitazone. Only 14% reported that they were using that medication. So small percentage. Small percentage were using metformin, which we know doesn't help for, we're using a medication that it's for diabetes, but we know it doesn't help in fatty liver. And 14% were using it for that. And then somebody mentioned vitamin E, and we do have evidence that vitamin E helps with fatty liver, but not in patients with diabetes. And some were using it in patients with diabetes, or even in patients with cirrhosis, and we don't have any data in patients with cirrhosis. So some common mistakes, just to show you that there is a lot of misunderstanding around this condition. So this is another evidence that I would say but I do mainly fatty liver, so I do think of fatty liver when I'm in front of the patient. But as physicians, we tend to forget about fatty liver. And we are busy, as they alluded before, so we only have 15 minutes with patients, and we have to go over blood pressure, diabetes, lifestyle intervention. Patients may have other problems, pain. And we only have 15, 20, 30 minutes, but it's not enough. So we have so many things to do. If you're in front of your primary care physician, colon cancer screening, mammography, DEXA scan for screening for osteoporosis. So there are so many things that fatty liver is kind of forgotten in the middle of all that. Okay, so this is just to show you, for example, how many of the physicians documented that patients actually had elevated. All these patients had it, okay? So they all had fatty liver, 251. But only 39 of those patients had documented that they had elevated liver enzymes. We were just overlooking them, okay? Or only 22% of those patients had in their chart that they had a fatty liver. Only 10% were referred to a liver doctor. 15% reported in the chart that they talk about lifestyle changes, okay? We see with these numbers how little importance we give in our visit to the doctors, okay? And that's something we need to change. But again, you are the best advocate for yourself too. And this is the survey on patients. And so many patients had limited understanding of what MASH means, and I don't blame them. Doctors have very limited understanding. If we cannot teach you, how are you expected to know? So patients rank impact of a treatment on progression to serious damage to the liver of low importance, suggesting a lack of understanding of the progressive nature of MASH. So they thought it was something static. Some patients are unable to differentiate between their symptoms were due to MASH or a comorbid condition. So MASH is usually asymptomatic, does not give you any symptoms. Some people may refer a little bit of pain in the area. Some people can have itching. But other than that, it's usually asymptomatic. And this is the one that I like the most. And this is our fault as physicians. We tell patients, oh yeah, remember to eat well. That's our recommendation. Less than 30 seconds. What does that mean, eat well? So we don't give strength to what we are saying of how important it is to change lifestyle. And because of that, patients think that when the doctor tells them, oh, eat well, it's not important, okay? And I will try to show you that it's important. It's hard because numbers are not in our favor for several reasons that we will try to talk, but it's feasible, and even small changes can help your health overall, okay? Okay, so who is at risk of liver disease? And I alluded to this already a little bit. Obesity, type 2 diabetes, kind of all the metabolic risk factors, high blood pressure. We call metabolic syndrome when you have 2 or more of these. Metabolic risk factor is just another name, but you may have heard it, so I put it there. Dyslipidemia, so your cholesterol or your triglycerides are abnormal. If you already have low platelets, that's a sign that you already have fibrosis or scarring tissue in your liver. PCOS, so it's also associated with fatty liver. There are some genes that may put you at risk. Do we test for them? No, we don't have to because they are not very common. But you may have heard that there's also some genetic background, especially among Hispanics. They have this PNPLA3. It's a genetic variant that puts you at higher risk. Smoking. And then ethnicity changes things too. So, and you can see that in this graph where you see how non-Hispanic blacks have a lower risk of fatty liver compared to Caucasians in blue. This is just in normal where the prevalence is pretty low altogether. So let's focus on these two. So you can see non-Hispanic black, lower risk compared to non-Hispanic white, but the highest risk is among Hispanics, okay? So it changes with ethnicity. That doesn't mean that a race is immune to fatty liver. It's just a little bit lower prevalence. As we age, we have more chances of having a fatty liver, and if you're a male, you also have higher chances of having a fatty liver. This is just to see how prevalent this is once you have a metabolic problem. So if you have obesity, I said 2/3, hypertension the same, cholesterol, so really high prevalences. So this is very common, okay? Not everyone will develop the more severe forms, but fatty liver is very common, so we need to tackle this obesity problem and these metabolic problems. We'll skip that one. Okay, so just to see, we mentioned gender, males more common. We mentioned ethnicity. I didn't have in the graph, but also Asians are at higher risk of fatty liver together with Hispanics. And obviously hypertension, diabetes, obesity, and having high triglycerides or low HDL, which is your good cholesterol. This is just to summarize, and I think I already sent that message, so now we will see what we can do. And some people ask me, why do I have a fatty liver? Okay? And I mentioned before that for me, fatty liver is a systemic disease. Okay? I understand you don't know much about normal physiology, but this will be very simple, trying to explain why do people develop a fatty liver. And I promise I use these same slides when I'm giving lectures to primary care physicians, even endocrinologists. So we do not know this very well, but I'll keep it as simple as I can. Interrupt me if I lose you in the middle, okay? But if you are fasting, okay, and you wake up in the morning, you haven't eaten all night, then your fuel is fat, okay? So your adipose tissue, where you store fat, is breaking that fat to give fatty acids, okay, part of that fat, to your organs so that they can use it as energy. So all our organs need energy, and when you are fasting, it's coming from fat, okay? The liver produces sugar because if you're not eating, your brain still needs sugar. So your brain cannot use fat. Your red blood cells cannot use fat. So there are some organs that depend on having some sugar, and your liver is in charge of regulating that. So while you are fasting, your liver is putting sugar in your blood so that your brain can use and your red blood cells can use. Okay? So that's fasting. What happens when we go and have breakfast? So we eat. So now there are nutrients coming in. So they include sugar, okay? So as that sugar goes into your body, you secrete insulin, okay? So insulin, what it does, it tells your body, we are eating, stop using fat because we will use the nutrients that you are eating, okay? So remember, you use fat that comes from your adipose tissue when you are fasting because you don't have food. But when food comes in, insulin tells your body, stop using the fat because now we have food, let's use the food. Okay? So it tells your liver, stop producing sugar because the sugar is coming from food. It tells your adipose tissue, stop releasing fat. We now have food, let's use it, okay? So now we are using this food. So it's glucose, and this is called a metabolic switch. So basically we went from using fat when we are fasting to using the nutrients from food after we have eaten, okay? That happens normally to all of us all the time. The problem is that when we start having some extra adipose tissue, overweight or obesity, that adipose tissue becomes sick because it cannot, as it grows, then it doesn't have the nutrients it needs. Because imagine vessels delivering blood to your body. If you have a lot of adipose tissue, the vessels cannot get there easily. So they lack the nutrients they need, those cells in your adipose tissue. So that adipose tissue becomes sick. And that's the core of the problem in fatty liver, that you have extra adipose tissue. And because this becomes sick, it doesn't pay attention to insulin. Remember I said insulin resistance? So your adipose tissue thinks you are fasting all the time, okay? That's a simplification. But your adipose tissue is trying to send fat to the rest of your body because it doesn't recognize insulin after you have eaten. It's insulin resistant. And because it's dumping fat to your blood, that fat is getting accumulated everywhere, okay? It accumulates in your liver. Now your liver becomes insulin resistant. It accumulates in your muscle. And I could put probably all your organs, heart, pancreas, kidney, vessels, they all accumulate fat. Okay? So this is a systemic problem where we have extra adipose tissue that's insulin resistant, and it's giving those free fatty acids to all your organs. Your organs start accumulating, and that's not supposed to be there, right? We are not supposed to accumulate fat in other organs. So those organs become dysfunctional. If they accumulate in the heart, heart disease. If they accumulate in the kidney, kidney disease. If they accumulate in the liver, fatty liver. And that's what we are talking about. Your liver has an enormous capacity of accumulating fat. While your muscle and kidney can accumulate maybe 3-4%, and that's super high, your liver can be 66% fat. 2/3 of the liver can be fat. That's how much it can store. And that's why it becomes sick in this condition. Okay? So now we understand why. So we have extra adipose tissue, and it becomes insulin resistant, and it delivers fat to all your organs. So we already alluded to this. I told you there are 3 new guidelines in the last 2 years. ACE, they are available online. So ACE in 2022, ASLD 2023, ADA renews their guidelines every year, and they 3 address fatty liver. Who do we need to screen for fatty liver? Well, basically, if you have a cardiometabolic risk factor, if you have diabetes or pre-diabetes, if you're overweight or obese, you need to be screened for liver disease, okay? There are some extra ones, like for example, well, if you drink more than a mild amount, we know that the combination of alcohol and having a metabolic disease is probably worse. And there's a new term, if you want to confuse things more, it's called MASLD, which is you have a fatty liver and you drink more than what we consider mild. We call it now MASLD. But so these are the list of things that in clinic we should be screening for fatty liver. So if you had to guess, if I were to go to primary care clinics and check how many patients get screened for fatty liver, what would be your guess of how many actually get screened for fatty liver? Yeah, I haven't done that study, but I can guarantee you that it's very, very small. And the number of patients that get referred to a liver doctor, even if the screening comes back positive and pretty high, it's very, very small. So we are moving a lot in the last decade, let's say, but we still have a lot of things to do to get this even better. Okay, so this is the diagnostic algorithm that is approved by those 3 guidelines. I don't want you to memorize it or anything. You don't need to know anything of this. The only thing that you need to understand is that primary care or endocrinologist, when they see you, they should be screening you with something called FIB4. And I was thinking about saying, like, do you know your FIB4? Like just an advertising, but I forgot to put it in the slide. But long story short, FIB4 is just a score that you can calculate with your age, your AST and ALT, and your platelets. All patients usually have that tested. It's just that we don't do the formula to calculate the FIB4. And that's the way we need to screen patients in clinic. So next time you see your primary care, you can say, hey, what's my FIB4, okay? So if it's less than 1.3, your chances of having fibrosis are quite low. If it's about 267, then your chances of having fibrosis are quite high, and you should probably be referred to a liver doctor, okay? The FIB4 is not perfect, but these are the guidelines we have. And it's new because before 2022, we didn't even have a diagnostic algorithm. Can you imagine that? We were telling people, oh, we need to diagnose fatty liver, but we don't know how. So, well, now we have this algorithm, okay? The problem is that 30% can fall in this indeterminate zone where we don't know if they have fibrosis or not, the scarring tissue. So in those, we recommend a second test. Could be a blood test called ELF, relatively new, not very well covered by insurance, so we have trouble with that. And we are advocating to get better coverage for the ELF test. And then the FibroScan, which is an imaging test, easy to do, but not available everywhere. So we have one at UAB that we use for research. We have ultrasound elastography, which is similar to that we can obtain for clinical purposes. And there's MRE, magnetic resonance elastography, that we are lucky at UAB that we have it for clinical purposes, and you can use it, and it gets covered. But that's not reality in many of the centers out there. So we still struggle a little bit with access to these things. FIB4 available any part of the world, no matter where, because it's just AST, ALT, and platelets. But after that, we are fighting to try to get better coverage and more easy access to these medications. Forget about the cutoff points. We are still arguing. We are updating one of the guidelines, so I'm participating in that, and we are still fighting amongst ourselves, saying what are the right cutoff points. But so forget about that. But long story is that we do have an algorithm, and it starts with FIB4. So that's what I want you to take home. So there's this thing, FIB4. Patients with obesity or type 2 diabetes should be screened for fibrosis in their liver, and that's the way it starts, okay? So what do we do with patients that have a fatty liver, okay? And we will have, if you have more significant liver disease, then it's one thing. We need to treat your liver disease and your fibrosis, okay? Just wanted to make sure I had a good amount of time. Okay, so if you have the inflammation, and especially if you have fibrosis, we will be focusing on specific treatments for your liver, okay? I heard you saying there are no treatments, or you heard there are no treatments. So for fatty liver, we used to say there are no FDA-approved treatments, and that's because we had drugs that were used for other things that would help for fatty liver, and we were using them, but they were not specifically approved for fatty liver. But that changed starting March 14th of this year, where we now have the first FDA-approved drug with a specific indication of fatty liver with stage 2 and 3, okay? There's an ongoing study for stage 4, so we cannot use it for stage 4 until that study is completed. But so we do have, okay? I'm not super fond of this new FDA drug just because we have a little bit of data, 1 year of follow-up, it's relatively new, and this is the same with any drug. Whenever something new comes, well, I want to see how it works first before I just jump onto it and prescribe it massively, okay? That's me being conservative. But we will talk about that, and we'll talk about treatments that have been out there for years, not with a specific indication for fatty liver, but for type 2 diabetes, but that they also help your liver, okay? And then remember that these patients die of cardiovascular. So if you have a fatty liver, you have a higher cardiovascular risk. And to be honest, many things can give you higher cardiovascular risk. So this is statistically speaking, okay? So if you are overweight, even if you don't have a fatty liver, you have increased cardiovascular risk. If you have diabetes, even if you don't have a fatty liver, you have increased cardiovascular risk. Then if you have a fatty liver, you're adding a little bit more. So we need to focus on controlling your cardiovascular risk factors, okay? And that's very important. Being aggressive, treating your blood pressure, treating your cholesterol if you have high cholesterol, treating diabetes to a good A1C, and lifestyle intervention to produce weight loss, okay? So we'll talk about all those things. Okay, so a couple of facts, but many people come to my clinic and said, doctor, what's the best drug? What's the best diet? So that's a question I get all the time. I say, look, if I knew what the best diet is, I wouldn't be here. I would be in Hawaii enjoying millions of dollars that I would have. But I do not know, and we don't know what's the best diet. And probably there's no best diet. It's probably what works for you. Because what studies have shown us is that compliance is very difficult, okay, long term. So most people can lose weight if they just focus on, okay, I will eat lettuce 2 weeks. Are you going to lose weight? Yes. Is it going to last? No, because the moment you go back to eating what you were eating, your body is so avid for those calories that it keeps them all and you regain your weight. And the other issue is that once we start eating less to try to lose weight, your metabolism goes down because your body is trying to keep your weight. Your brain sets at your highest weight and tries to keep that weight as hard as it can. So when it senses that you are eating less, it will try to prevent you from losing weight. It will lower your metabolism. So you can say, oh, doctor, I changed my diet. I'm eating better. My weight is exactly the same. So many physicians think, oh no, the patient is like, no, they are not. They are eating less, but their metabolism now is lower, and it's matching that, and then your weight doesn't change. So this requires sacrifice, and it's hard. Even in control settings where we look at patients every week, and they get phone calls in the middle, and they meet with a personal trainer, and we give them the diet that they need to follow, the success of weight loss after 10 years is 10%, 10 to 15%. So pretty low long term, okay? And that's with no medication. So we will talk about medications as well. So, but that doesn't mean we don't need to encourage it, okay? Because we think, oh, it's only 10%. I will not waste my time off clinic because I only have 20 minutes. I don't want to, because I know the patient is going to fail. No, that's incorrect. So 10% will achieve long-term weight loss. Some other percent will achieve some weight loss, and the more we push for it, the higher our chances of getting success, okay? And that's proved by the fact that weight loss clinics do much better than primary care physicians, because we focus on your weight, we only talk about weight, diet, and pharmacological treatments. So don't get discouraged. It's a long journey, it's a marathon, where you will start losing weight and maybe regain some. So it's life, we understand, but don't lose the long-term target of I need to improve my health. And what I said about the diet, so it's what fits you. Some people say, look, I do well not eating for 16 hours a day and then just eating 8 hours, intermittent fasting. Can I do that? Yeah, if you do well, if you don't get a headache after 16 hours of fasting, go for it. So we know it helps losing weight. Some people say, no, look, I love everything I eat. I'm not willing to change anything on my diet. I tell them, okay, you just need to cut portion size. Eat exactly what you're eating, but 1/3 of what you are eating needs to go. So if you were eating, I don't know, 3 slices of pizza, now go to 2. And you can still eat the same. That works for some people. Some others can improve the quality of what they are eating, because they don't want to feel hungry, so they want to eat the same amount. Well, it's a matter of changing the quality. So the strategy you use, it's what fits you and your everyday and what you like, and and what you can keep over time. That's what I tell patients. Whatever things you can keep over time. We don't want to do this shock diet where you lose weight, because most likely you will regain it. But if you are drinking regular sodas and we can take those out. If you're drinking sweet tea and we can take those out. I usually tell patients, don't drink any calories, save them, because we all enjoy food, right? So, and if we have a set amount of calories that we should eat, then don't drink them. Just find something that you like drinking that doesn't have any calories. I wanted to put there Mediterranean diet. It's just the one with more publications. So we usually say there's more evidence on Mediterranean diet. But as long as you're losing weight, your liver will improve. Coffee, that's just a fun fact. We don't know exactly if it helps or not, but there are some observational studies that drinking coffee, especially in the US, apparently there's an European study that was negative. But so patients usually, that I get that question, does coffee help? Yes, it does based on observational studies. We don't know much other than that. Yes?
Do you plan to talk any about ultra-processed foods?
Not specifically, but we can.
Okay.
No. So that's a good question. So that goes into what food quality, right? So processed food, first it has a lot of salt, so already bad in that setting. So frozen or canned food, they usually put a lot of salt to try to keep it good for a long time. So, and then there are several studies showing that processed food is associated with higher cardiovascular disease. So yes, ideally you want to try to avoid processed food, eat as healthy as you can, vegetables, lean meat, fish, and then Mediterranean diet, which is a little bit higher on carbohydrates, but then fat are the healthy ones, so omega-3. So. Does that answer your question, or you had any specific question about it?
The food in the industry, in this country in particular, there is a very high focus on more and more and more ultra-processed foods, but it seems that there's a lot of evidence that none of the ultra-processed foods are good for you.
Correct.
Period.
Yeah.
I mean, they're just not.
Yeah.
So the less of them that you can eat,
Yeah.
you should be seeing some health benefits pretty quickly.
I agree. Yeah. No, I agree with that statement. There's a lot of money involved in all the food industry, so you will have, but. Oh, sorry, yes, we'll go to your question. But let me finish with this before I forget it. But so there's a lot of fight between those that produce sugary drinks, criticizing artificial sweeteners, saying, oh, no, artificial sweeteners are not good for you. From a metabolic standpoint, artificial sweeteners are completely neutral, okay? There's no bad evidence. I've reviewed this literature on artificial sweeteners. So yes, there's a 2010 study suggesting that in males, not in females, it was associated with leukemia. It was an observational study, but imagine what, obesity was also associated, and those that were taking artificial sweeteners were more obese than those not taking it. Because they were obese, they were taking artificial sweeteners. Long story short, that study was then repeated in a different cohort in the UK, no association with leukemia, but you will hear cancer and artificial sweeteners. There's another study suggesting cardiovascular disease with sucralose, which is one of the artificial sweeteners. If you look at that study, several biases, and it's also an in vitro study. So I usually tell patients artificial sweeteners are most likely safe. Can I sign it? No, in medicine I cannot. But very large studies have not found any evidence. That's why we sell them. Now, is there any evidence that sugar is bad for you? Yes, everybody knows it. So we are comparing something that we don't know, that maybe if we were to do a study in 6 billion people, maybe one would be affected with something, comparing to something that we already know it's bad for you. So go for it. If you like artificial sweeteners, I will endorse them. Okay? Yes. She was there first.
No, I just wanted to make a point on what the young lady was saying. With processed foods, if you cut them out of your diet or limit them, I had to do it as a little patient. It really does have an impact on your overall health, not just the weight part of it, but your overall health. And one of the other things that I did was I cut out sugary drinks, and I started drinking cranberry juice and water. And it just made such a difference in how I felt during the day. I didn't feel lethargic with all the sugars in my system. But I just wanted to reiterate what she was saying, because that's so true about processed food. And we all do it at some point, stop on fast food because we're rushing. But at the end of the day, that food is just not for the human.
Yeah. Also, very good points, but also remember juices do have sugar, so I usually, even any kind of juice, I usually tell them it's grabbing a fruit, squeezing the sugar, throwing away the fiber. So fruit as a whole is better than just juice, but yeah, try to avoid sugar drinks. Any, yes?
Yeah, one other thing, there is a big problem with labeling of food, because they put food out that says low fat, no fat, low cholesterol, and people that have, my mother was diabetic, I couldn't ever get her to understand if they don't put sugar in or they don't put natural stuff in, they're putting a lot of processed bad stuff in, and she would eat it and go, oh, this is low fat, this is no fat.
Yeah, very good point. Yeah, I usually tell patients that, imagine if you have a product that has 50 grams of fat, the FDA may allow you to call it low fat if it has 45, but still a lot of fat, but you can put that label. And then, for example, you can eat chips that said 0% cholesterol. Yeah, cholesterol comes from animals. This is potato and oil, so there's no animal fat. So obviously it's 0% cholesterol, but it has saturated fat that your body converts into cholesterol. So yes, very important to pay attention to labels. Always look at carbohydrate content and fat content. The specific label, don't believe the advertisement. Yes?
This is your fault, by the way. You said we can interrupt you.
No, absolutely, yes.
No, I think one of the things I wish we would talk about, and I try to, is for a lot of people, food can be an addiction, and we don't talk about it that way. It can be just as addictive, especially sugar, but it's just as addictive. In my family, it's alcohol and smoking and drugs, and it's so frustrating to me because I don't eat my feelings. I'm sort of the opposite. When I get really depressed, I stop eating. And guess what? When people saw me looking below 100 pounds and skeletal, they were concerned and they spoke up and said something about it. But on the opposite end of the spectrum, and it's you can't address it that way. You can't talk about it that way. And so it's just more common than anything else. I wish doctors would talk more with patients about food as a possible addiction and what is going on that is causing you to eat beyond being full, for example, because that's where the psychosocial support needs to come in.
Yeah, absolutely. Yeah, and obesity is a very heterogeneous condition where patients may be obese for different reasons, and yeah, it's hard. It's difficult to change habits, but yeah, I agree that there's so much we don't do in clinic, and that we barely, even when I run a weight loss clinic, I don't have time enough to talk about all the things that I would want. So.
Is psychosocial support the part of the clinic?
So we have they meet with a dietitian as well after they see.
I mean a mental health professional.
And we do have one. It's not routinely for every patient that comes, but we can schedule it if we think that could help. Yes, she goes to clinic I think twice weekly, so there may be a little bit of waiting, but yeah, we do have she's specializes in obesity, and she's a psychologist. Yeah. Okay, I have like 2 minutes to move and exercise as well. Very important, okay? So, and this is kind of the usual guidelines that we tell patients that we don't emphasize enough. And I tell patients, whatever you can do is good, okay? I don't want you running a marathon tomorrow because then you feel discouraged. I also tell it's 3 weeks. Any change requires 3 weeks where you will feel miserable. This is what I tell patients. If you drink regular Coke and you try the diet one, you don't like it. It's too sweet. But if you drink diet sodas, if you try the regulars are too sweet. So how can that be? And it's because your taste bud gets used to something. So I tell them, look, just switch for 3 weeks. You will be miserable. You won't like it. But after 3 weeks, you will like it and you won't go back to that one. And the same is true with the exercise. When you start, you don't like it because muscles hurt, you feel tired, you're eating more because you're hungry. So it takes a little bit of a process, so don't get discouraged in the first 3 weeks. And weight loss, it's very important, and it's the key. No matter what type of approach you use, what matters for the fat in your liver is the amount of weight loss, okay? So if you want to do intermittent fasting, if you want to do diet and exercise, if you want to do weight loss medications, and we'll talk about those because there's so much data of the benefit of weight loss medications that I do want to use my last, probably by now I ran out of those 2 minutes. Yes, I did. But how much weight loss? 5% to improve fat, 7% to improve the inflammation, 10% weight loss to improve even the scarring tissue. And that goes in line with what we see in bariatric surgery, that if you have a lot of weight loss, even the fibrosis can go down. Not everybody, we don't understand that no turning point, but many patients are able to decrease the amount of fibrosis. These are some medications that we already mentioned, but I want to emphasize the use of GLP-1, semaglutide, and there's a new one, tirzepatide, okay? They are weekly injections, both approved for obesity, both approved for diabetes, both with histological data showing improvement of MASH. One, we already know that improves your cardiovascular disease. The other one, the study is ongoing, but we don't see why not, because they work similarly. And semaglutide also show that it protects your kidney. So imagine a drug that produces significant weight loss, around 15%, that helps your heart, prevents MIs and stroke, and helps your kidney. So the problem is coverage, right? So it's expensive medication, but if you have diabetes, you may qualify. If you have obesity, some insurance also coverage. So this is something that it's changing the field, and it's going to change it even more as they become generic. They've been in the market for quite some time. And I did mention resmetirom as the first FDA approved specifically for fatty liver, so you will hear about it. This one, if the other one was expensive, this one you don't even want to know. It's like $50K a year, just because they are the only one in the market, so they want to get benefit out of it. But we only have data in 1 year, so yes, it can be good if you have the right patient, but we don't have any cardiovascular safety or effect. We don't have any kidney effect. The other ones are already on the market. They have been in the market for many, many years for obesity and diabetes, and they do have cardiovascular and kidney benefit. And this is just to give you hope. Many, many drugs in clinical trials, so this field is changing fast, okay? And it will continue to grow, and we'll have more options. Many of these medications produce weight loss, so there's lots coming on. But in the meantime, let's use the tools that we have. And with that, I will stop, just saying that this is very prevalent, progressive. It affects your cardiovascular disease. So early diagnosis and treatment is crucial to change the natural history of this. Thank you.